Assalamu alaikum. Today I would like to talk about primary hyperaldosteronism. Before jumping into the evaluation, I would like to talk about the pathogenesis of primary hyperaldosteronism. What happens in the primary hyperaldosteronism? There may be bilateral nodular hyperplasia and there may be hyperfunctioning of adrenal adenoma. There may be a hyperfunctioning of adrenal adenoma. What it will do then? It will increase aldosterone. It will increase aldo. It will increase potassium excretion, thus causing hypokalemia. It will increase potassium excretion. It will increase hydrogen excretion, thus causing metabolic alkalosis. And it will increase sodium reabsorption and increase sodium reabsorption causing hypertension and increase blood volume, hypertension and increase blood volume. And as there is increased hypertension, so RAS will be low, decrease renin, decrease aldo, decrease angiotensin 2, and hypertension and increase blood volume, which will increase the renal blood flow. It will increase the renal blood flow. It will increase the GFR, glomerular filtration rate, and it will increase the atrial natriuretic peptide. And we know the ANP, atrial natriuretic peptide, and along with these three can cause increased sodium excretion, and it will increase sodium excretion and which will limits the edema, and it will limits the edema, and that is the aldosterone scale. So hypertension, increase blood volume, which will increase the renal blood flow, increase the GFR, and increase atrial natriuretic peptide, and thus it will increase the sodium excretion and it will limit the edema. This is the pathogenesis of primary hyperaldosteronism. In short, I'm telling it again that in primary hyperaldosteronism there is bilateral nodular hyperplasia. There may be hyperfunctioning of the adrenal adenoma, which will increase aldo. Aldosterone increase aldo will causing retain sodium, so increase sodium absorption and decrease or excrete potassium. Increase potassium excretion, thus causing hypokalemia. Increase hydrogen excretion, thus causing metabolic alkalosis, and increase sodium reabsorption, causing hypertension. Increase blood volume, which will increase the renal blood flow, increase GFR, increase atrial natriuretic peptide, and thus limits edema. How? Due to increased sodium excretion and increase hypertension, decrease renin, decrease angiotensin 2. So that is all about the pathogenesis of the primary hyperaldosteronism. So if you find a patient with hypertension and hypokalemia, what you will do then? What you will do then? You will do plasma renin activity and plasma aldosterone concentration. Hypertension and hypokalemia. The next thing you have to do, plasma renin activity and plasma aldosterone concentration. If plasma renin activity is high, plasma aldosterone concentration is high, plasma aldosterone renin ratio approximately 10, plasma renin aldosterone ratio approximately 10. If both are high, plasma renin is high, aldo is high, and concentration is approximately 10, it is secondary hyperaldosteronism. If plasma renin is low but aldosterone is high, primary hyperaldo is high and renin is low, primary and plasma aldosterone versus renin ratio more than 20, pack PRA ratio more than 20, and pack uh, plasma aldosterone concentration more than 15, it is primary hyperaldosteronism or Conn syndrome. Then adrenal CT tomography to determine the etiology. Adrenal CT tomography to determine the etiology. If both are low, plasma renin activity is low, aldo is low, then it is other causes of hypertension and hypokalemia. It may be due to congenital adrenal, it may be due to the cage, congenital adrenal hyperplasia, Cushing syndrome, it may be altered aldosterone metabolism, it may be glucocorticoid resistance, it may be exogenous glucocorticoid, exogenous mineralocorticoid, it may be exogenous mineralocorticoid. So low plasma renin activity, low plasma aldosterone concentration, it's the other cause, it's in the cage. And if it is secondary hyperaldosteronism, it may be due to diuretic, it may be due to cirrhosis, diuretic cirrhosis, CCF, renovascular hypertension, renin secreting tumor, it may be coarctation and malignant hypertension. These are the cause of secondary hyperaldosteronism. So I'm talking it again, like if a plasma aldo is high, plasma renin is low, aldosterone is high, renin is low, so it is primary hyperaldosteronism. If plasma aldosterone concentration is high and the renin is high, it's a secondary hyperaldosteronism. If both are low, it is other cause of hypertension and hypokalemia, and other causes are like cage. That what does cage means? Congenital adrenal hyperplasia, Cushing, congenital adrenal hyperplasia, Cushing, altered aldosterone metabolism, glucocorticoid resistance, and exogenous mineralocorticoid. If both are high, plasma renin is high and aldo is high, it may be secondary hyperaldosteronism. It may be due to DCR like diabetic use, cirrhosis, and congestive heart failure, coarctation, renovascular hypertension, and renin secreting tumor, and primary hyperaldosteronism. If we look at this chart, another chart, hypertension and hypokalemia, do plasma aldo by plasma renin ratio. If plasma aldo and plasma renin ratio is normal, if plasma aldo and renin ratio is normal, evaluate for other causes. If it is elevated, do adrenal suppression test. If it is negative, evaluate for other cases. If it is elevated, plasma aldo by renin concentration more than 20, it is, if it is elevated, do adrenal suppression test. If it is negative, evaluate for another cause. If it is positive, do adrenal imaging. Normal CT and age more than 40 with abnormal CT, do adrenal venous sampling, but discrete unilateral adenoma age less than 40, age less than 40, discrete unilateral adenoma, consider surgery. If normal CT, age more than 40 with abnormal CT, adrenal venous sampling. If it is unilateral adenoma and hyperplasia, consider surgery. If it is bilateral, if bilateral medical, unilateral adenoma and hyperplasia, consider surgery. And adrenal venous sampling, aldosterone is to renin ratio 4 times higher in adrenal adenoma on one side of the tumor, no difference between two sides in patients with bilateral. So this is all about if you find a case with hypertension and hypokalemia, this is the way of going to find the causes. And finally, this box: primary hyperaldosteronism, aldo is high, renin is low, and primary aldo by renin ratio is high. Aldosterone by renin ratio should be more than 20. In secondary hyperaldosteronism, aldo is high, renin is high. Primary aldo by renin ratio is normal, and non-aldosterone mediated both are low. And secondary hyperaldosteronism, we know that it may be renovascular hypertension, it may be malignant hypertension, it may be renin secreting tumor, reninoma. And non-aldosterone mediated maybe Cushing syndrome. It's like a cage, Cushing, altered metabolism, and exogenous glucocorticoid. They may be glucocorticoid resistance and altered aldosterone metabolism. So this is all about hypertension and hypokalemia. Hope you enjoy.